available after the session on the PMG portal in the Meaningful Use Connecting Healthcare section of the portal. Today's topic is about Consent Manager. Very interesting project and could have some big implications for you and for actually all of the providers in the state of California. So in addition to myself, we've got Becky Shoemaker, who is our HIE project manager and is the lead on this project. So a word about our mission here at Santa Cruz Health Information Exchange and PMG. Our goal is to improve the quality and efficiency of healthcare for everyone. That includes not only providers but patients and their experience, to offer technical assistance and guidance and best practices, to provide tools to you to help connect you to the Santa Cruz Health Information Exchange and get more benefit from it, and to incorporate these tools into the projects that are going on around the county as well as the nation, such as accountable care, clinical integration, medical home, and surviving healthcare and payment reform. So starting this discussion is a bit of education and discovery. There's consent means a lot of different things to different people, and it also has a couple of different implications. So in this context, first of all, we're talking about consent to share data in the Health Information Exchange. We're not talking about consent to treat or other things like that. So it's purely around sharing data, and it only applies to the virtual health record, the longitudinal health record. Your records are not impacted, meaning that we're not trying to restrict the exchange of data into or out of your system. And so it's business as usual under the laws of HIPAA and the state of California for exchanging data for treatment, payment, and healthcare operations. Many of you are today users of the virtual health record, the community view or the longitudinal patient view. We know because more than 35,000 records are viewed in the virtual health record around the community throughout each month. And that number has been steadily increasing over the last 18 months. And people tell me they're getting a lot of benefit out of it. So if you're not already a user or regular user of the VHR, please contact Becky or Dawn here and get access. It is part of the Elysium Health Information Exchange system that we run, and it's the same login. It's not a different place. It's just a different selection on the menu that you go to. So again, for those of you that are not familiar with it, I won't spend a lot of time, but what is in the VHR is a pretty comprehensive view of all of the patient data from around the community that's legally shareable. So we've got data from EMRs, we've got data from inpatient and labs and hospitals and referrals and medications. So let's get into consent. So consent to access electronically. There's a sort of a national or a federal notion that electronic sharing of data is different, that HIPAA is not enough. And I'd say this is more of a notion than it is a law. There's, in fact, a patchwork of laws around the country around this. Several years ago, many people that thought about this, about longitudinal health records and sharing of data, thought, well, we should have a federal standard for how these laws apply. And I actually spoke to the people in Washington that make these laws and make these decisions, and what they pretty conclusively told me was that the states and the governors of the states feel that this is a states' rights issue, that the governors looked at this and said, as a state, we issue driver's licenses, we issue marriage certificates, we have, police and whatnot, and regulating healthcare is a state's rights issue. We're kind of lucky here in Santa Cruz that we don't really have a bordering state nearby, but you can imagine when two states share a border and there's significant patient and doctor flow back and forth across the border, and the two states have different laws, how challenging that is. So again, we're probably lucky that we're here. A number of states have passed laws about health information consent to share data, and some of them were pretty ill-informed. They rushed ahead, and they turned out being written by a bunch of lawyers and a bunch of people that maybe would be considered privacy advocates or maybe over-advocates, and tried to represent the concerns of the consumer. But some of the states have really passed onerous or impossible laws, and that really impacts your ability to do business and your ability to treat patients. So California actually took a pretty interesting approach, which we'll get into in a little greater detail. In addition to states passing laws that have had negative effects, many organizations place their own rules and restrictions that hinder coordination of care, promote redundancy and over-ordering of tests, and actually endanger patient safety. I think a good example of this is the Veterans Administration. And the Veterans Administration has required that their patients positively opt in, meaning that they say, I will share my data with other doctors that are involved in my patient care. Well, it turns out that only 5% of the veterans have done that. So if you've ever had the pleasure of treating a veteran, and I know we don't have a veterans hospital of any significance close, what you'll find is that there's very little data the VA is willing to share with you because they did not get that prior agreement from the patient to share. That's compounded if the health information exchange also requires patients in advance to give certain rights to share. So in some places that I've spoken to in Colorado and in San Diego, even though there's large veteran populations and veterans hospitals, the amount of sharing that goes on is virtually nil because it's almost impossible to get the stars to line up. Over the years, that will hopefully change. There's two common models for consent. One's called opt-out, which is what we follow in Santa Cruz, and the other is opt-in. So the opt-out model says that all permissible data is stored and shared for valid HIPAA purposes unless the patient has explicitly opted out. So I put that little clip there of what it looks like. Today it says consent to access unknown, by policy yes, meaning that unless a patient has said no, then their data is shareable for permissible purposes, which include treatment, payment, healthcare operations. The opt-in model, on the other hand, that a number of states and organizations have elected to go with, says that unless the patient says yes in advance, then their data is not shared. So again, that's not what we have been following for 16 years here. In either case, the data is shared for treatment. So if you're the ordering doctor or you're copied to or referring, you can view what is pushed, but you would not see the data in the longitudinal health record if the patient has opted out by saying no. So like I said, we've been following this opt-out model since 1996. It is legal. It has been looked at by lawyers. It's been looked at by the state of California. And the state of California, through the Office of Health Information Integrity, has actively been working on this for a number of years to try to solve this, to give the stakeholders, both the physicians as well as hospitals and systems, some guidelines so that they can safely know what they can share. They did come up with some proposed legislation in 2010. I reviewed that, and I came to the conclusion that electronic exchange would come to a screeching halt if they passed it. Luckily, they did not pass that legislation, and last year, with the new Deputy Secretary for Health and Human Services, Pam Lane, she said, let's take a new approach. Let's find out what you, the doctors, think. Let's find out what you, the practices, you, the HIEs, think about how we can operationalize this and pass some laws that make sense. So what's really exciting to me, and what I hope you keep in mind, is that in 2 or 3 years, we are going to have legislation, and this is your opportunity to participate in shaping what that looks like. So if you complain about the law they pass, if you didn't participate in this project, you'll have less of a leg to stand on. Conversely, this is your opportunity to help us all pass good legislation. So Deputy Secretary said, let's do some demonstration projects as opposed to trying to cook up legislation with a bunch of lawyers and big thinkers around the table. So there's 3 demonstration projects. The Inland Empire HIE, which is probably the biggest by geography HIEs in the country in Southern California. They have many, more than a dozen hospitals, I think somewhere around 5,000 doctors. They are in the demonstration project. The San Diego HIE is in the demonstration project, and Santa Cruz is in. And they gave us all a little bit of money to help us do this project. And we hope that these demonstration projects will lead to the right legislation. Again, probably in 2015 or maybe even 16 till we see the actual legislation come out. And the benefit here, I think that we, at a HIE level and at an ambulatory care level, we think, hey, let's share the right information to treat the patient and to have it be efficient and effective, and let's just do it. Well, we think that way, but big organizations don't think that way. They think about liability, and they think about problems, and they need these kinds of legislation and guardrails to identify how to do it. So if we have these rules of the road, it's going to promote data liquidity so that the data can flow easily from person to person and system to system, legally and safely. And we're going to get to better healthcare outcomes, because having data to treat the patient at the point where you need it, at your fingertips, we think is going to lead to better healthcare outcomes and coordination of care and all of the other goodness that comes with having the information that you need to treat a patient. We are doing this to evaluate the effectiveness. This is what Cal OHI is looking for, to evaluate the effectiveness of privacy and security and understand the impact on you. There's a financial cost to everything that you do. We know that, the state knows that, and when they ask you to do more things, if you will, unfunded mandates, then we all realize it's a problem. So how can we make this as easy as possible, as well as look for better ways to do this so that it's not a burden? And that at the end of the day, we want to engage consumers more in their health care, and we want to build the trust between yourselves and the patients, and have confidence in the data exchange. So we have this Cal OHI consent project. The period is this month, March and April, out through September. We have partial funding by CHHS, some of which we're going to share with you, and some of which went into technology and people. And we have some funding and support by PMG as well that we'll be sharing with certain PMG contracted providers. So the incentives that we're looking at here is that we have incentives that are applicable for any physician. There are some limits. We currently have 12 physicians that have already signed up, and there's 2 incentive opportunities. And the first one is a $500 check for participating. If you participate in this program, and we'll talk about what that means in a minute, you'll get half when you sign up to participate and the other half at the end of the period, assuming that you actually did participate and didn't just sign up for it. And we're giving that to the first 21 providers, so there's still a little bit of room, a good bit of room there for more providers to sign up and get the $500 each. The second is the PMG contracted provider 2013 extra credit points. I can't tell you how many dollars that means in your pocket, but it is part of the bonus program that we have going on for electronic usage in 2013, and that will factor into your bonus and will increase the bonus that you get from PMG by participating in this program. For each doctor, the actual bonus is going to vary. So again, I can't put a dollar number on the PMG bonus, but we can put a dollar value on the money that we're passing through from the state, the $500. And people can participate in both. And if once we have 21 providers, the 22nd provider won't get the $500, but they will get the potential to do the extra credit if they're a PMG contracted provider. And I put Becky's phone number down if you'd like to talk to her with some questions and participate, as well as her email address. So when you contact Becky, she is going to set up a meeting to bring our materials out and show you and educate you and your staff on what this means. You will be giving your patients another form to sign along with the forms that you give them when they normally come in. I know we all hate forms, and one of the outcomes of this could be how can we make the forms simpler and less burdensome for both the practice and the patient. But at least for this demonstration project, we have a simple one-page form that is given to the patient that you ask them to look at and sign. And then we ask either you or us to change or update their status in Elysium, and I've got a screen for that in a moment, to set their consent status. And then we ask you either to scan the consent and attach it in Elysium, or Becky will come and pick them up, or you could fax them or scan them to us as a bundle at the end of the week. So we want to make this as easy as possible. We know no matter how we cut it is extra work, but we do want to make this successful and give good information back to the state. The view that I wanted to point out is that if you go to change the consent yourself, if you have that capability, what I want to highlight is that in the patient index, consent to access, as you see here, is set to unknown. And this is the change consent status. This is where you're setting what the new status is and the reason and who took it. And you can upload the document here that the patient signed. Or again, you can give these to us and we'll do all that work for you, at least through the demonstration project. So what's the result of the patient registering to not share information? In other words, if you give them that form and they say, oh, this is a really bad idea, I don't want to do this, and we have another form. And that form, number one, tells them the benefit of sharing information, of why they would want to share information, and it does give them an opportunity to fill out a little form that says, I do not want my information in the virtual health record. And that you would have to give to us, and we would make that entry. We've been running for about a month now with our early pilot sites, and we actually only have one patient who has said, no, I do not want my data in the VHR. So it's very minimal. And I will point out that other states and other health information exchanges that are doing consent and have been doing consent in some cases for years, that typically it's about 98 to 99% of patients do share. They're fine with sharing. It's that 1 to 2% that have some concern. So one of the things we expect to see is, well, how do our numbers compare with other places like Rochester or some places in Nebraska that are really aggressively enforcing this. So again, if a patient has said, no, I do not want to share my data, in the Elysium VHR, the patient will be listed as emergency only. And in that case, any provider that feels that they have an emergency reason to see the data anyway can do the break the glass. And that will be a little button that says, I want to break the glass. I attest that I have a treatment relationship with this patient and it's emergency. I want to see their data, even though they've said no. Providers, you'll still be able to see the patient name, date of birth, but you won't see their clinical data, again, if they've said no. There are some exceptions to this. So even if a patient says do not share, there still are legal implications, there's public health, and there's contractual obligations. So if there's a subpoena, we or you can still share data. If there's a public health, by law, they have certain rights to data. Even if the patient has said no, public health gets a pass and can see the data. And if there's a contract, an example of this would be a patient that has a contract with PMG for their managed care insurance. We have nurse case manager working on their situation. Even if they've opted out and said, no, I don't want to share, that nurse case manager by contract can see their information to coordinate care with you and with the patient. In terms of Elysium, eLight, the web-based Elysium that many of you use for lookup and referrals and things, there's no change. All the data that's there today is going to stay there. The functionality is the same. If you're ordering something, you're going to see the results in your Elysium system. If you are forwarding things, you can forward to another physician or another user. Again, even if the patient has said, no, I don't want to share the data, this is for treatment purpose, you can share. It's only that it would not be visible in the VHR. And of course, there's no change in your practice system and with your interfaces. All the data that's flowing in and out today will continue to flow in and out through the interfaces to Santa Cruz Health Information Exchange, even if the patient has said, don't share my data. So we have these forms, documents, educational materials that Becky will provide you to give you and your staff a briefing on what is involved and what we're asking you to hand out to patients. And I do want to stress that the model that we're testing that was approved by California Health and Human Services is that we are testing opt-out, that if the patient does not opt in, their data is still shared. Let me say that again. So if the patient looks at the form and says, I can't decide what I want to do, I'll do something later, their data is still shared. It's shared in the VHR until they would say positively in writing, do not share my data. So no data is going to go away as a result of this until a patient is actually asking for it not to be shared. As part of one of the reasons we're able to float some money to you is we have to get some information from you. We need to know your experience with this. We need to know your suggestions. We need to take this and aggregate it and feed it back to the state, again, so that they can come up with, hopefully, a consent process for the legislation that will work for you, ultimately, over the long term. And we have a patient survey, which is optional. If the patient wants to share some information with us, we'll take that, aggregate that, and feed it up to the state, and hopefully we'll make it into the legislation as well. The project is 6 months of data collection and then analysis, so we're going to wrap this all up by the end of the year. Just a further emphasis on the same point, which is this applies only to the VHR. Your records are not involved, so they're not constrained in any way different from today. Coming up next, so we're at the end of this session, next is our direct messaging.